Time to apply the nursing process to a client with an unmet nutritional need. Most clients have some sort of unmet nutritional need. So we'll start with assessment. Assessment can start with history. So we'll ask them about a diet recall, 24-hour diet recall is the easiest one to do. What did you eat in the last 24 hours? Because if you ask a patient, well, tell me about your eating habits, and give them that big open-ended question, they'll probably tell you, oh, I eat healthy. I eat a lot of things. Ask them what they eat in the last 24 hours. You might want to ask them to keep a 3-day food diary to get a better picture of what kinds of foods they eat, or you might want to do like a food frequency questionnaire. Usually you'll have a good form to guide you, but it would go something like this. How often do you eat? How many times a day do you eat whole grains? How many servings of fruit and vegetables do you eat? How many servings of low-fat dairy? So you want to know what foods the person eats in what frequency, and that would be another assessment you could do. You would ask about different limitations that people might have. Are you experiencing any problems with your eating? Are you having any anorexia, which is lack of appetite? Are you having any nausea and vomiting? Do you have problems chewing? Do you have problems swallowing? Have you had recent loss of weight? Have you had recent weight gain? And so those are some things that you might want to ask. Additionally, you will want to know about religious prohibitions on certain foods, and maybe some ethnic or cultural food preferences. And of course, any diseases that have a nutritional component are going to trigger a whole bunch of other questions. Now, when it comes time to physical assessment, one of the simplest things we're going to do is to calculate that person's ideal body weight. Well, let's look at height and weight first. And there are a lot of different formulas for finding an ideal body weight and figuring out how that person is in relation to where they are. And one of them is the BMI. It's the most common one you're going to see. It's the easiest one to calculate on most, when I do an admission assessment, I enter it into the electronic health record and it calculates the BMI for me. There are fancy formulas for doing it. I think there's probably one in your textbook, and yes, there is on page 693 in a little box in the upper right corner, box 27.4. However, my best suggestion is to get an app on your phone, if you're so inclined, and just plug the numbers in and you'll get a BMI. What's more important to me is that you know what's normal. And so here are some numbers for you. Normal is 18.5 to 24.9 according to your book. Overweight is 25 to 29.9. And what I would let you know, one of the things that I have against BMI is that it really doesn't discriminate age, gender, muscle mass, bone structure, anything except the height and weight. And so if you look at the charts, overweight includes a lot of people that by our culturally acceptable standards don't seem overweight. However, statistically they are at risk for more illness than people who are in that 18.5 to 24.9 category. Obesity is defined as greater than or equal to 30 BMI. And so those people are definitely people you want to target for intervention for weight loss. And obesity preventing and treating has become a major public health initiative because it is one of the biggest contributors to poor health in America. Now, in terms of physical assessment, obviously when you assess your patient, you can tell a lot about their nutritional status by their overall appearance. If they're very fatigued, if they're very pale, you could be looking at a problem with anemia, which has a nutritional basis because of iron and folic acid and B12. You will also look at the hair, skin, and nails, and mucous membranes, because those are the places where cells turn over the most rapidly. So that's where you're going to see a lot of your deficiencies. So those are some of the things that you're going to start looking at. For more specific information, we will talk about that extensively in Nursing 137 when we get to that part. But you will start to look at your patients and determine you'll get little clues about their nutritional status from their physical appearance. So we can talk a little bit about laboratory evaluation. Now your book talks about blood glucose in kind of simpler terms, but I will tell you about glucose. The body likes to maintain it at a stable range, and it has a number of mechanisms to kind of keep it within that normal, above 50 but below 127, which is what your book defines as normal. Usually it's between 60 and 120, but it's not always directly related to nutritional status. It tells you more about the pancreatic reserve and the person's status with diabetes. So, but we can look at glucose as a measure of whether that person's carbohydrate intake is adequate in relation to how their pancreas functions. If they're getting really high glucose readings, like I said, normal pancreas, normal healthy body will maintain that glucose no matter what you eat within a narrow range. But people who are diabetic, if they're getting these wacky numbers, then their carbohydrate intake is too high in relation to how their pancreas can handle it and in relation to their current medication regime. So if they're compliant and they're still getting high glucose, you might have to look at carbohydrates. But that's enough about glucose. Albumin is an indicator of protein status. But by the time your albumin levels are low, you're usually a little bit behind the 8 ball, because it can take up to 3 weeks for your albumin to be low when you are in a starvation state. So when our albumin is low, we know we have malnutrition, we have malabsorption, you could have liver disease, you could have loss of protein through burns or wounds. So a more sensitive indicator of albumin is prealbumin. Those levels, they fluctuate a lot more, and so they'll tell you more about a person's protein status at that moment. And obviously, if you're worried about a person with malnutrition, you can look at the prealbumin to see if your interventions are effective, if their problem is getting better, if it's getting worse. Iron studies, it's another thing we can do. There are a lot of things that we can measure, but transferrin is one of them, and that is a protein that binds with iron, and that's another early indicator of whether or not the body is getting adequate iron. By the time your hemoglobin drops, you could be pretty far in advance, and your hemoglobin count might not go up immediately when you start enriching the diet or supplementing. So a better response to intervention kind of test is the transferrin. But that's your laboratory evaluation for the nursing process. Once your assessment is fairly complete, you can start to make a nursing diagnosis, which is where you identify the problems. And we have a few that directly address a nutritional problem, particularly our imbalanced nutrition diagnoses. So imbalanced nutrition, less than body requirements, and sometimes our related to factor there is loss of appetite. So related to loss of appetite, as evidenced by patient only eats 25% of the food on the meal tray. Or we could have imbalanced nutrition more than body requirements, and this can be caused by overeating. So we might say imbalanced nutrition more than body requirements related to overeating, as evidenced by BMI of 36. So that's another good nursing diagnosis. Then we have self-care deficit, and specifically this self-care deficit relates to feeding. And so we would make our statement, self-care deficit, feeding related to altered mental status. Maybe we do a secondary thing, and I know you were taught about that. Secondary to Alzheimer's disease, as evidenced by patient forgets meal times frequently. So then risk for aspiration is a diagnosis. It's a potential diagnosis. It's a potential problem that can happen when a person's eating. We could do risk for aspiration related to difficulty swallowing, as evidenced by patient gags and coughs at mealtimes, or as evidenced by facial paralysis. So those are some nursing diagnoses that directly impact nutrition or address a nutritional problem. Now we have some nursing diagnoses that might show sort of a causative effect on our nutrition problems. For example, nausea causes a lot of problems with intake. And so there is an added approved nursing diagnosis that is nausea, and we might want to pull that out and make it a separate target for intervention. So nausea related to medications, as evidenced by patient states, I'm too nauseous to eat. Or we could do altered nutrition, less than body requirements related to nausea. We can have deficient knowledge as a causative problem for nutrition. Deficient knowledge related to low sodium diet, as evidenced by food recall that reveals high sodium foods. Non-compliance related to diabetic diet, as evidenced by glucose levels above the desired range. And so there are different nursing diagnoses that address nutritional problems. Now we're at the part of the nursing process where we can actually help people, which I always find exciting. I always, when I was in school, liked the nursing interventions piece of it the best because that's where I could actually do something to help somebody. So just going to call your attention to this. This is your volume 2 of your fundamentals text. It's that soft cover book that accompanies the main text. And for this unit, pages 513 to 517 have these little clinical insight boxes. Right before that, there's a lot of procedures. Also a good reference to back up your Smith and Duell text. But 513 to 517 have a lot of really good helpful information that will help you sort of make some interventions for your patients. So if you're doing a care plan or if you're doing a focused assessment or focused review for ATI after some assessment, that's a great source of information, and it's also good to help you study for this. Okay, so some nursing interventions we're going to do. Now I'm going to say that in America we have a lot of people with deficient knowledge and non-compliance, so probably our number one intervention for these folks is going to be to educate. Now your education is going to be tailored to the patient's specific knowledge deficiency, but for most people we're going to educate our client to select a healthy diet using the method that the U.S. Health Department has chosen, which is the My Plate method of meal planning. Okay, so let's get a picture of My Plate up there. I have a really good one for you. There it is. Blow it up so that you can see it and so that all the writing is visible. So just take a look at that, and the first thing that I want you to notice is this. The entire half of the plate is fresh produce, or it could be frozen. But you want to use as much fruits and vegetables in that diet planning as possible, and you want to get them from a variety of sources because one vegetable might be high in something and another might be high in something else. But really you want to have as much produce as possible on that plate. So instead of having a little tiny dish of green beans on the side, which is what a lot of people are used to, you want to really, really fill that plate. And vegetables should be the first thing you plan your meal around, really. The U.S. Health Service advocates that you buy fresh vegetables in season and keep frozen vegetables on hand. And that's because, as we talked about, the longer something sits, whether it's in a produce truck on its way to your grocery store or whether it's in your fridge, the more nutrients that food will lose. So buying foods in season guarantees that A, they're going to taste better, which will encourage you to eat more of them, and it will encourage that the nutrient value of that food is highest. Of course, that's not always possible in the dead of winter. It might be tougher to find foods that are in season, particularly if you try to eat locally, which a lot of us do, and you live in an area that doesn't have that long a growing season. You want to plan your meals around that vegetable main dish. Maybe you want to have a stir fry, and your protein food is almost like a condiment in that stir fry. The other advice I say, keep cut up vegetables in your fridge where you can see them and grab them really easy. I love doing that, especially when you have kids. Sometimes they don't want to eat the cooked vegetables. They don't like the texture. Maybe they get a little soggy. But they usually, if you give them a little bit of ranch dressing, will gobble up all those raw vegetables, and they're good for you too, and that way you don't reach for the chips or the other maybe unhealthy snacks. You can also shred things and kind of hide them in foods. You can chop up spinach and put it in pasta sauce. You can put shredded carrots over your salad to increase the nutrient value there. All little sneaky tips you can do. Now, of course, fruit's nature's dessert. And when you kind of wean your taste buds off of the highly intense sweet foods, you'll notice that fruits in their natural state are really delicious. They have a lot more flavor than a lot of your high sugar foods. And so there are lots of little tips you can have. If you do have canned fruit, which, if you're living in an area where it's hard to get those fresh fruits and vegetables, make sure that you're purchasing that canned fruit either in water or in its own juice and not in heavy syrup or light syrup. Syrup is just another word for sugar.
Okay, so the other half of your plate is going to be made from grains and protein foods. Now here, the plate is divided so that the grains are just a little more than half. Now, here the advice is to make half of your grains whole grains. I would go a little further. You're going to encourage whole grains for most of your grains. White bread, white rice, white pasta, things made from refined flour or refined grains typically have much poorer nutrition, and they have less fiber, and so they're not as good a nutrition source. It's almost kind of a why bother. You're eating it just to fill yourself with quick carbs, which is not, the goal here. So we want to try and substitute whole grain products as much as possible. Whole grain breads, whole grain pasta, grains in their natural state, brown rice, barley, bulgur, quinoa, millet. There are lots of good whole grains. Oatmeal. So those are the kinds of foods you should select for that part of the plate. Potatoes, even though they're a vegetable, those starchy vegetables can go in this part of the plate too. Okay. Then we have protein foods. Go lean with protein. Now, there's lots of good plant-based proteins. You have things like hummus and dried beans and peas. Nuts are not a very dense source of protein. They're mostly high in fat, but they do have protein. So you can use those sparingly, I would say, just because the calorie count can be very high. And so when we talk about lean meats, we're talking about a de-emphasis of your red meats, unless they're very, very lean. Most beef is a lot higher in fat, and the kind of fat you get from those red meats tends to be more saturated, which again is associated with heart disease. So chicken and fish, white meat chicken without the skin, fish. With fish, you can eat fattier fish because the type of fat that is in the fish is omega-3 fatty acids, which are actually beneficial to your heart. Things like ground turkey to substitute for that ground beef, to make turkey burgers, turkey meatballs. You can use vegetarian type proteins, veggie burgers. Stay away from anything really highly processed, but tofu definitely a good source if you like it, and if you know how to prepare it. But make your protein lean. Eggs are a great source of protein. Egg whites are very low in fat. The whole egg won't kill you though. So up at the top we have dairy. So you have your plate. Then here it says use like fat-free or low fat, meaning 1%, not 2%, to get your calcium. Milk also has a good deal of protein that's easily digestible. But if you are one of those folks, there is a vegan food plate. I mention it because there is a fair number of people who are going towards a more plant-based diet. So you can use plant milks that are calcium fortified. So that's your My Plate method. My Plate can be adapted if you look in your text or if you look online. You can find that there are My Plate diagrams that are tailored for different ethnic groups, for different types of dietary constrictions. It's a very flexible way to plan your meals, and it also helps you control your portions. The old food pyramid was a little confusing for people. They would look at it and say, well, I have to eat a lot of bread or a lot of potatoes. I have to eat, the grains are the healthiest thing. And so they would see 6 to 11 servings, and their idea of a serving might be really 3 times the normal amount. So the My Plate method has replaced the pyramid method of planning. Everyone knows what a plate looks like. It's very easy to teach somebody. Divide your plate in half. Start with fruits and veggies. Then a little more than half of the second half of your plate, so a little more than a quarter of the plate should be whole grains, and a little less than a quarter of the plate should be lean protein. It's a lot easier to educate your client using this method. And just so you have it, here is the link for the Healthy People website. It gives you a lot of really good information about the United States Department of Health's goals for the public, but you'll find out a lot of information about the My Plate food method, among other things. You can get some good printables off of there. We may use it for an in-class exercise, but that's the link for that. So another common problem that you're going to deal with clients is going to be altered nutrition, more than body requirements. These are people who have issues with overweight or obesity. Frequently they come to you for help. If not, they come to you because they have other conditions, diabetes, hypertension, high cholesterol, whatever the issue is. We want to get their weight back to normal. So I have some tips up on the screen. I'd just like to discuss, what are the characteristics of people who successfully lose weight and maintain that loss. They eat breakfast every day. They monitor their diet intake and they weigh themselves regularly. They maintain a low-calorie diet after weight loss. It's not like they cross the finish line and they're done and that's it forever. They maintain the consistent diet, whether it's a weekday, a weekend, whatever. They engage in high levels of physical activity, at least an hour a day, and they have social support. So that's how our interventions are kind of coming about. If it helps to weigh yourself regularly, then definitely have this patient weigh themselves weekly. If you do it daily, some people do, and it's not wrong necessarily, but you will fluctuate a lot more. If you weigh weekly on the same scale, in the same clothes, at the same time of day, that's going to be more accurate information for that person. We like to encourage people to track their food because people who monitor their dietary intake tend to do better. So you encourage a food diary, or there are apps for food tracking like MyFitnessPal. Your iPhone has the capacity to do that. And of course you want to educate your client about a healthy diet and exercise. And a healthy diet's not going to include any sugary beverages. You're not going to have excessive alcohol intake. Those things have a lot of calories that don't do anything for your body. Encourage them to grill, bake, broil their food as opposed to deep frying or sauteing in heavy amounts of oil. If you do saute, that's fine, but use smaller amounts. Whenever people use oils, and I'm not against the use of fats in the diet, they should have a teaspoon in one hand and make sure that they're measuring. It shouldn't just be a free pour out of the olive oil bottle. Well, we want to encourage exercise, and by exercise, when you're trying to lose weight, the recommendation is at least 60 minutes most days. Now, that's hard for people to maintain, and some people might be resistant and they might give up. And so, sorry, there's a lot of Lego activity in the background. You just have to bear with me for a minute. But you want to encourage any kind of exercise is better than none. Walking is fine for most people, particularly people who are obese who may have problems with their joints. It's a lot of stress to put on ankles and knees and hips. So maybe we want to encourage lower impact exercises or swimming, elliptical. Classes are fun. People have social support, do better. So if you can get them into an exercise program that encourages some socialization, that's great. And always be supportive of people. Don't judge them. Obesity is a health issue. It's not a character flaw. And it affects so many Americans. Really, you're there for your client. You're not there to make them feel bad about themselves. You're just there to give them the information and support they need. So, okay, next we're going to help the patient who has altered nutrition less than body requirements. This is the patient who's malnourished. And the first thing we're going to do is assess for the underlying cause. What is it that's causing this person to be malnourished? Is it because they have COPD and they have poor appetite? Is it because they can't access food? Is it because they have mental health issues? That's what we're going to target for intervention. The next thing we're going to do is to offer this person high-calorie, nutrient-dense, protein-dense food when they're likely to be hungry. Don't wait until after physical therapy when they're wiped out and they don't want to eat. You can also offer food that's easier to chew. You have cancer patients or patients who have other issues that make them so tired that even chewing seems like work to them. For those people, maybe you want to have something like egg salad or something like puddings that have full-fat milk, full-fat yogurts, things that are easy to chew but high in calories, high in nutrients. You're definitely going to want to consult with a registered dietitian for this patient if they come in and they're what we call cachexic, C-A-C-H-E-X-I-C. You don't have to memorize it, but know that that's a term we use, where they're very emaciated and they don't have enough nutrition. We want a dietitian in there to make a full assessment. That's their specialty, and we work with them, but you can certainly defer to those professionals. You're going to weigh this person once or twice a week. Again, you can weigh daily, and sometimes you will, but your best information is going to be if you do it once or twice. People do fluctuate because of fluid balance and other issues. Offering high protein supplements. Sometimes that comes in the form of Ensure or Boost or something similar to that. And clients with eating disorders, these are people who it's really a mental health issue that impacts their physical health. For those folks, they need to see somebody who's qualified. And you're going to get more information on eating disorders. I think it's a 1 hour unit of content you get in Nursing 133, which is our mental health nursing. But it's not something you're going to tackle on your own, like you just give them a tray full of high-calorie food and expect them to eat it. It's a very complicated problem. So those are some of your nursing interventions for that. The next problem we're going to address is the client with a self-care deficit that involves feeding. Now, I know you had a lab on this, so we don't have to labor it to death, but I do want to cover it because it's something you need to know. Obviously, if a patient has a problem feeding themselves, you're going to assist them. You can usually delegate this to a nurse's aide or to a family member, because you're really going to only be able to help 2 or 3 patients eat. It's a 20 or 30 minute thing. You can't prolong it. And I know I've worked in long-term care settings where, maybe there were many patients on the floor that needed to eat, not enough people to help. So you're going to try and have at least 2 to 3 people. If that family member sitting at the bedside doesn't mind, and the patient's not at high risk for aspiration, certainly go ahead and utilize them and have them assist you. So one basic principle, always elevate the head of the bed if they have to eat in bed. Otherwise, you get them up to a chair or out to the dining hall if it's long-term care. If they are in bed, adjust that bedside table so that you have the most natural setting. Also, when people are laying flat, they can choke. So we want them elevated as high as they can comfortably tolerate. Now, again, you've had this in a lab. If the patient can feed themselves, but maybe they have an issue with manual dexterity because they have arthritis in their hands or whatever it might be, you're going to open their packages, you're going to cut their meat, you're going to peel their fruits, things like that. If you want to pour something for them or open straws, that can be helpful to them too. Patients that are visually impaired or blind, you just kind of tell them where the food is using the metaphor of a clock face. For example, your potatoes are at 12 o'clock, your pork chop is at 4 o'clock, your green beans are at 8 o'clock. And that would be one way that you could assist a patient who can feed themselves. Now, patients that can't feed themselves, you're going to have to feed them. But sit down while you're doing it. Don't rush to get through it. Don't shovel. Think about how you would feel. I know in the lab you had to feed each other a little bit. Make sure you provide adequate time so they can chew the food and swallow it. And you can serve, try to serve finger foods to clients who can manage that much. Maybe your patients with cognitive impairment, they can manage a finger food where they can't manage a fork or knife. People with hearing impairments, you might have to make sure you have eye contact and cue them a little bit with gestures. And try and make the mealtime as relaxed as possible. Before you start feeding somebody or assisting them with feeding, make sure they've had a chance to toilet and wash their hands and all that stuff so that they can sit down and enjoy their meal and you're not interrupted like 12 times while you're doing it. And so that's how we handle self-care deficit. Okay, so now we come to the client who has nausea, and nausea is a big problem in the hospital. People are on meds that cause nausea. Constipation can cause nausea. Radiation therapy causes nausea. Any kind of problem with the bowel, including your fresh post-ops whose peristalsis may have slowed, can have nausea. Anesthesia can cause nausea, a lot of things. Morning sickness, pancreatitis, there's a lot of different causes. So if we can treat the cause, we do. Obviously, if they're pregnant and it's part of their hormonal status, there's really, you kind of have to ride it out. But make sure that you have everything ready in case they do throw up. You have an emesis basin, you have tissues, you have water. I always have a little bit of mouthwash. It makes people feel better. Provide frequent mouth care. When they do vomit in the emesis basin, usually it's great to have 2 so that you can take one away and clean it and it's not just sitting there. That's only going to make the person more nauseous. But be attentive when they do throw up. Make sure that the room is full of fresh air without bad smells. Most units, you can find some kind of spray that neutralizes obnoxious odor. You can't help but have odors in a hospital. It's just the way it is. But make sure you're not wearing really obnoxious perfume. Tell visitors maybe not to wear so much perfume. Food smells a lot of times. When you're working labor and delivery, nausea is pretty common at certain points of labor, particularly at the very end when it gets very painful. And a couple times I've had people come out to the desk, oh, she's nauseous or she's throwing up, what do we do? And I walk in the room and there's a great big pizza box and I can smell hot wings or, meatballs or fish. Certain cultures like to give people fish for after delivery. And you're like, you got to get this stuff out of the room, and then you have to kind of deal with that. A cool temperature usually will promote a relief of nausea. Hot makes it worse. However, if people are also feeling kind of chilly for whatever reason, you don't want to make them too cold. Just maintain a comfortable room temperature. Allow the patient to wear loose clothing. Most patient gowns are appropriate. If they're wearing their own clothes, kind of encourage them not to wear anything too tight. Avoid foods that are greasy and spicy, that smell a lot, and really usually cool foods or cold foods are better tolerated for most people than warm foods. Whatever the patient can eat, they should eat. And you'll find sometimes exceptions to these rules of like spicy or whatever, that maybe for them they can eat something heavy in fat like peanut butter and it's okay, whereas the next person can't. So if they can tolerate oatmeal or crackers or whatever, don't worry too much about hitting all the food groups or whatever they tolerate they should have. Smaller, more frequent meals, definitely. Instead of giving them 3 great big hunkin' Thanksgiving dinners, give them maybe 6 mini meals, a half a sandwich or something like that. They can have little sips of ginger ale or cola. Watch out for the carbonation. You don't have to make it go totally flat, but make sure they don't gulp it. Your book says drinks with sugar calm the stomach, which is sort of counterintuitive when we're telling people not to drink sweetened things. Certainly if your patient's diabetic, you're not going to give them regular cola, but there is something about ginger. So diet ginger ale could be appropriate for those patients that can't tolerate sugar. You can have them suck on an ice cube or a popsicle, or take little tiny bites of Jell-O that they kind of just hold in their mouth, or a piece of frozen fruit. That sometimes is enough to provide relief. And as a collaborative intervention, you're certainly not going to go ahead and do it without an order, but antiemetics like Zofran or Reglan, very, very helpful to people, particularly people with cancer. We talked a little bit about vitamin B6 with people who have pregnancy-related nausea, but that's something that you'll want to consult with your provider about. And certainly if they're having issues with nausea and vomiting, it's not inappropriate to call a provider and ask for an order, and they very seldom will tell you no. So that's nausea. So the next client that we're going to plan care for is the patient who has difficulty swallowing or who is at risk for aspiration. And I'm going to put this up first. I'm going to give you a little star to go with it, because I want you to remember, you definitely need to position the patient so that their head is elevated as high as tolerated. Up to 90 degrees. Sitting in a chair is better. The flatter they lay, the more chance that they're going to aspirate. And you're going to leave them in that position, that high Fowler's or 90-degree position, for at least 30 minutes to 45 minutes after they eat. And that's about the time it takes for the stomach contents to empty into the small intestine. So that's one of the ways we're going to prevent aspiration. Another thing that I want to teach you is not to leave your client. It sounds obvious, but people sometimes just don't think. They get into their thing, they hear a call light go off somewhere else. Never leave your client right after you've fed them or during a feeding. And don't delegate this job to somebody who's not qualified. Certainly if they can't suction that patient, they shouldn't be in a position where they might need to. So don't leave your client and don't delegate if they're at high risk for aspiration. You're going to continually monitor level of consciousness. If they're really not alert and they're drowsy, this is not the best time to try and feed them, because that's when aspiration will happen. Be alert for cues like coughing or gagging. You're also going to check for things like some clients will pocket their food. They make like a little pocket between their cheek and their gum. So kind of check in there before you walk away from the bedside. Make sure that they're not going to, they're not saving something for later and they might choke on it. Have suction equipment available. This is something you should do really in every room. Every time you admit a patient, you should make sure that there is a suction canister, that there's tubing, that it all works, that you have maybe a yank hour, which is a special catheter for suctioning. Make sure that you have it, make sure it works. Check it every shift. As part of your routine morning assessment, you're assessing your room, you're assessing your patient at the same time, and you're ready for that emergency if you need to. But particularly for this client, you're going to be on heightened awareness that they may need to be suctioned after they eat if they start choking. We're going to give them, small bites of food, and we're going to give them lots of time to chew it. Again, you had this in a lab, so you probably remember if you don't give people time to chew, they're more likely to choke just from the overload that's in their mouth. You might need to remind a patient, particularly somebody with altered cognitive status, somebody with dementia, Alzheimer's, that they need to chew or that they need to swallow, and make sure that they, do that for you before you give them the next bite. On the topic of chewing and swallowing, you got to make sure that your food is the appropriate texture, and for most of these people, it's either mechanical soft or it's pureed, okay? And a pureed food really doesn't need to be chewed very much. A mechanical soft diet might have some lumpier textures, to make sure that the person chews. Make sure if they have dentures, that those dentures are in. It's hard to chew your food when you don't have teeth. Liquids, a note about liquids. Now, your book in volume 2 says avoid liquids. Obviously, you're not going to avoid all liquids. It's kind of cruel and unnecessary. What you might need to do is to thicken liquids. And for that, usually you're going to get a recommendation from a swallowing evaluation. If you have a patient who's got difficulty swallowing, you're going to get a swallowing eval, and that's usually done by speech. And they'll make a recommendation that your liquids are thickened to a particular consistency. Honey or nectar, we all know what honey looks like, as opposed to, say, like something more like pancake syrup, which is a little thinner. But you'll get a recommendation for that texture. And on the unit, usually there's a little can of something called Thicket. There are other brand names for it. But it's there to thicken liquids, and there are always instructions on the side of the can. Use this many scoops to, 1 cup of water to make it nectar consistency or honey consistency or whatever you're doing. But make sure that all food and liquid that you offer is the appropriate texture. Avoid drinking straws. Drinking straws kind of help you suck it down quick. We don't want anything sucked down quick because it gets sucked down in the wrong place and now you got problems. And then you're going to, we'll do this one next. Let's say your patient had what's called a CVA or a stroke. They've got facial paralysis on one side only. Sort of mesh these up so that they're not in the way. And we're going to put that food on the unaffected side. It sounds like common sense, but sometimes people get in a whole, I've got to get this job done and go on to the next thing. And they forget their common sense. So if you've had a patient and you look and their one side of their face is drooping, that's the side they're going to aspirate on. So put the food on the other side, or teach them to put the food on the other side. And put it sort of in the middle of the mouth. Don't put it right on the tip of the tongue, as they're going to spit it out. If you put it way back far, they can gag and they'll choke on it. So put the food on the unaffected side. And then there's, you can do a chin to chest kind of maneuver, where you tuck the chin into the chest. And try and fix that for you. Yeah. And that will help kind of close off the, the glottis so that the food goes back into the esophagus and not down the trachea. And again, the higher up somebody's sitting, see if I can get you a picture. Hold on one sec. The better off you are in terms of helping this person. This person is sitting in a chair and she's being fed. Hopefully she's on a mechanical soft diet there. But, you're always going to be assessing them. Leave them in that upright position so that, if they have any kind of regurgitation or reflux, it doesn't go back down the wrong tube. Okay, and that's our interventions for that. Now, obviously, if a person has so much difficulty swallowing that feeding them becomes an exercise in risk, you might have to recommend the placement of an NG tube, or the physician might, or the provider might order an NG tube or a PEG tube. So we'll kind of talk about that in a little bit. We're going to talk about some medical interventions for our various problems. We're going to pick up our discussion on the medical interventions for clients with nutritional needs just where we left off. Those folks who have difficulty swallowing might need to be fed through a tube if it's just too risky to feed them orally. And so we have NG tubes, or nasogastric tubes, and they go through the nose and into the stomach. Here's one.
nasogastric tube. We have orogastric tubes. It's what we use for the little kids usually because they're nose breathers and we don't want to narrow their airway. There's a little guy with hydrocephalus. He's got an OG tube. You can see it's taped to the side of his face with a tegaderm, and that's pretty standard. And then if you need something a little more longer term, those NG tubes and OG tubes are really only meant for short-term use. So if you need something for more than, say, 6 weeks, really more than 2 in most cases, if you think you're going to need it for a while, you're going to want a gastrostomy tube that goes directly into the stomach through the skin with a surgical incision. This needs to be done by a surgeon. They make a little stab wound and they put the tube in. Now, this PEG tube is sutured in. And you can get them where they're little gastrostomy buttons or gastrostomy tubes that have like a balloon similar to a Foley that you inflate, and they can be changed out. The ones that are sutured in need to be replaced by a surgeon if they get clogged, which happens frequently. So your responsibilities as a nurse at this point in your career, I don't want you fiddling with anything you don't know as a student. If you see a nasogastric tube, I don't want you really doing anything with it without supervision. But what I do want you to do is make sure that that person's head is elevated at least 45 degrees, preferably higher, to prevent aspiration of stomach contents. It can happen. So make sure that your client who has those feeding tubes always has their head elevated. If you're pumping fluid in faster than that person can tolerate, they're going to have some reflux. If they have regurgitation into the pharynx, it's possible they can aspirate it into the lungs and cause themselves a nice aspiration pneumonia. And that cannot happen on your shift. Trust me, it's not fun. Okay, so that's enteral feeding tubes. Then there are some medical interventions for obesity. We have medically supervised, very low-calorie diets, VLCDs, usually like Metafast or OptiFast, and they may include the use of liquid diets. So that's one intervention. Then we have bariatric surgery, and that's something that those of you who come up to 2A with me are going to see a lot of because that's where they put the post-ops for that. And bariatric surgery for the patient who has tried other methods, less invasive methods of weight control, patients who have comorbid conditions like diabetes or hypertension or high cholesterol or sleep apnea. Bariatric surgery is one of the most effective means we have of controlling weight. Typically with just plain old diet and exercise, about 95% of people who lose a significant amount of weight will regain most of it. Bariatric surgery, on the other hand, about 2/3 of the people will keep it off. 1/3 will gain some back, but it's just something you should be aware of. There are different types of procedures. As you get to clinical, you'll see some of those. There's gastric bypass, sleeve. So, those are just different procedures. I don't want you to get too bogged down into them. Just know that they are things you can see, and they are interventions for obesity, which is a very serious illness. There are some medications that are a little less popular. Orlistat, we kind of know that as Ally over the counter. Kind of helps the food pass through so you don't digest the fats. Unfortunately causes some pretty nasty GI side effects, like really messy diarrhea. Then there are some like Contrave that work on the brain to reduce appetite. Not as popular, but those are some things that you might see. Now for patients who can't have enteral feedings of any kind because there's something wrong with the digestive tract, we have total parenteral nutrition. This has to be ordered every day. It usually goes through an outside source, comes up around 4 o'clock in the afternoon. After 24 hours, whatever is hanging needs to be taken down. Total parenteral nutrition includes amino acids and glucose and vitamins. Has to be given through a central line or PICC line. Cannot be given through normal IV. If you see anybody try to give it through an IV, stop them immediately and come get somebody smarter, because you can really harm a patient that way. Lipids can be given. Lipids come separately from your TPN, and they usually come up in a big glass bottle and they're white. They can go through a peripheral IV, a line that's in your wrist or your arm, but they need a special filter. So those are some things that you might see in the hospital. The exact formula of TPN varies. It's individualized for the patient. Again, it's a physician order, has to be reordered every day, but that's TPN.
And the next thing we're going to look at are special diet orders, and it's important for you as a student nurse to understand the difference between the special diet orders. Sometimes the kitchen will send up a tray. Learn to follow my stars, guys, because that tells you what I think was important for you as a student nurse to know, and therefore a testable concept. So a tray might come up, and it might have a number of items on it, and some of them might not be appropriate for a patient in context of what their diet order is. For example, you might have a clear liquid tray and up comes cream for the coffee. Well, that has to be taken off the tray, and it would be the nurse's responsibility to make sure that those diet orders are maintained. So, our first diet order, the one that we're going to talk about, very commonly seen in the hospital before procedures and before certain tests, lab tests, patient might be NPO. It can happen sometimes with vomiting too, if they're severely nauseous and nothing's working for them. So NPO means nothing by mouth. Sometimes you'll have a diet order that says NPO except for meds and sips of water. Before a procedure, they might not want the patient to skip their medications, and so they'll allow for medications and sips of water. But the big thing about NPO, there should be a sign on the bed, and obviously if somebody calls out to the desk and you want to be super helpful student nurse, and they say, can you get me some crackers or a glass of water, or please nurse, can I just have something for lunch? Don't try to be helpful until you've checked to make sure that that person can have those items, because if they're NPO before a procedure or test and you go ahead and get them those things, maybe now we have to postpone that procedure and nobody's going to be happy with you for that. Clear liquids is another diet order we might see. And clear liquids are frequently ordered for your fresh post-op patients because we can have altered gastric motility and they might get nauseous and not tolerate those fluids. We start with clear liquids. They don't supply a lot of calories or protein or other nutrients, so hopefully we're going to advance that diet to something a little more nutritious soon. If they're more than 3 days on clears, usually they're going to have some kind of liquid protein supplement or something like that that's in a clear liquid format. Things that are included in clear liquids, let's make a little box. You might see it again. So water, obviously, and ice chips are clear liquids. Clear juices. So your apple, grape, cranberry, but not orange. Okay, so if that's something you see on a tray. Oh, a liquid, by the way, is something that's liquid at room temperature. So Jell-O, even though it has a solid consistency, gelatin is considered a clear liquid, because if you were to leave that at room temperature over a period of time, it would melt and become liquid. So popsicles, again, they're solid when they're frozen. When they melt, they're liquid. As long as they're clear popsicles, no creamsicles, no fudgesicles, just a popsicle. We can give them broth, chicken broth, beef broth. Usually it's pretty disgusting in the hospital, but it is something you can give them. And like ginger ale, Sprite, cola, a lot of your carbonated beverages are fine for clear liquid diets. So that's your clear liquids. Tea and coffee. Let me make a note with tea and coffee. The only thing about tea and coffee, no cream, no milk, not even skim. Skim milk is not a clear liquid. So nothing in it. So if the tray comes up, this is something that might commonly happen. You have a tray of clear liquids, and you've got your juice, and you've got your Jell-O, and you've got your popsicles, and you've got your broth, and you have a little can of Shasta, whatever. And then you have a cup of tea, and then there's 2 little creamers on it. Well, it's the nurse's responsibility to take those creamers off because they don't constitute a clear liquid diet. Okay, so that's your clears. Full liquids means anything that is liquid at room temperature. So ice cream is a full liquid, milk is a full liquid, creamer in your coffee is a full liquid, certain soups are full liquids, and they have to be pureed or strained so that there's no solid parts in them, but those are some things that are allowed on full liquids. So hot cereals like cream of wheat can be considered. Oatmeal is not because it's chunkier, but cream of wheat is considered a full liquid. Yogurt can be considered a full liquid. Pudding is considered a full liquid. Ice cream, all juices, including orange,
You can have custards, that kind of thing, milkshakes. So this varies your diet a little bit, and of course with the addition of dairy products, you now get a little bit more protein and a little bit more nutrition, so more vitamin A, vitamin D, calcium, magnesium, phosphorus. So you get more nutrition from a full liquid diet than you do with the clear liquids. Okay, so that's why we want to advance the diet. Pureed or mechanical soft, this is for people with swallowing difficulties, and that's just, like baby food texture is pureed. Mechanical soft means something that you can gum, even without teeth pretty much. So this is a good diet for people who have problems with dentition, or if they are very tired. Like I said, those cancer patients, you give them like a little egg salad, ground beef goes under this, things like that. Pureed has to go in a blender. Then we go on to diets that are sort of targeted towards different disease states. If you are obese or if you have diabetes, you might be on a calorie controlled diet to help you lose weight. And there's usually a count that goes with that. So, an 1,800 calorie diet or, a 1,500 calorie diet would be calorie controlled diet. Diabetic diets, there are a number. There's not really one diabetic diet anymore. There used to be the ADA diet, which was the American Diabetes Association diet. It had exchanges. That has been sort of outdated for a number of years. You'll still see it ordered sometimes. However, a lot of hospitals are going to what they call a controlled carbohydrate diet, or a CCD. I know Capital Health is one of them, and that's where the carbohydrates are the things that are controlled. So a patient can order a number of things on their tray. If they want eggs and bacon and toast, the toast has to be counted in the controlled carbohydrate diet. And so they might be given a diet with a number of carbohydrate choices. It could be 3 carbohydrate choices, which are like 15 carbs each, 15 grams of carb each. Milk would be a choice, bread would be a choice, any starch or starchy vegetable would be a choice, and fruit would be a choice under those controlled carbohydrate diets. Again, that's sort of one of those things that if that pertains to you in the hospital, if you have a patient on that kind of a diet, you need to check their tray and make sure that the carbohydrate content or the calorie content is roughly whatever was ordered for that patient. Now we have a renal diet because the kidneys excrete extra protein. When they're impaired, there's going to be an issue with protein. So we're going to control for protein. There are also certain nutrients like potassium and phosphorus that need to be controlled. And so, your renal diets are usually very low in protein, low in potassium, low in phosphorus, to account for the fact that the kidneys aren't functioning well enough to excrete any excess. Then we have our cardiac diet, which is a low sodium, low fat diet. You can also have a diet that's just low fat or just low sodium. But on 2A, you'll see a lot of people on that cardiac diet. And so they might have 2 grams sodium a day. So they won't have any salt on their tray. Their tray should not contain things like a lot of canned soups or broths. The food should be relatively low salt. Processed meats like ham, salami, hot dogs, sausage, those have a lot of sodium, so you would expect not to see those on a low sodium tray. Low fat diets can be ordered not just for cardiac conditions or weight control, but low fat diets are also ordered for like gallbladder patients. And so things like butter, cream, high fat meats, high fat cheeses, full fat dairy would be omitted from those trays, and if you saw them, you would take them off. You would look for things like skim milk, broiled chicken without the skin. Instead of butter, maybe you'll have a light spread. Those are the kinds of things you would expect. You would not expect to see cream for your coffee, but you might see some skim milk or something like that. Protein controlled diets have lower protein counts, and those again are for people who have problems with liver or kidney disease. When you get to those units and that content, you'll see why that pertains, although the liver things may be changing with that according to evidence-based practice. Don't get too far ahead of yourself. Then calorie protein push, just like it sounds. These people need more calories, more protein, so we give them foods that are denser in those things and usually some supplements like Ensure. So those are your special diet orders, and if I were to focus your studying efforts, I would say know your real popular ones, your clear liquids, full liquids, let's get another star, full liquids here. I would want you to know about your low sodium or your low fat diets. Those are the ones that are most commonly seen. And of course, NPO, if you have a patient who is NPO, you want to know about that, and definitely don't give them anything. So lastly, we are at the end of this unit now, thank goodness. We're going to evaluate the outcome and see how this patient responded to intervention. So things we're going to look at, obviously it depends on what our original goals were. Does the patient's behavior indicate that they understood what we taught them about nutrition? Are they using the My Plate method to eat more fruits and vegetables and to limit their intake of junky foods? Are they taking in the low-fat dairy and the lean protein and the whole grains? Are they adhering to their dietary instructions? If they were on a low-sodium diet, is their chronic condition controlled? If it was for hypertension, if they're diabetic, do their blood glucose numbers reflect that they follow their dietary instructions? Are they making progress toward their weight goals? Are they gaining or losing weight as appropriate to the diagnosis we made? If they had problems with swallowing and aspiration, they were at high risk. Have they maintained a patent airway? Have they aspirated or not? So we want to know, are these interventions effective? And if not, then we have to reevaluate and make a new plan. And if they are, then, obviously we're resolving that issue. We know that our planning was appropriate and effective. Our interventions were effective. And so that is it for nutrition. I know that nutrition and oxygenation together are quite a lot of information, so it's good that we get it out of the way now. Moving forward, we have a lot of littler units. They'll be hopefully a little bit more manageable in size, but this was important information for you to have, so it will lay a foundation for you. It's good for this content, but also moving forward, it's going to be really critical information to have in all of your coursework. So thank you for sticking with it, and I'll see you in class.